next year.
So welcome everyone, good morning. It's Friday of what's going to be a lovely weekend, and want to welcome Dr. Marissa Sitt and her resident team for what promises to be very interesting rounds. The topic looks very intriguing. So Marissa's a comprehensive ophthalmologist here in Toronto, works at the Toronto Western Hospital. She did her MD at Toronto and as well as her residency here. She's been heavily involved in resident surgical teaching for many years as she runs our resident simulation lab. So thank you, Marissa, and welcome to your resident team.
Great. Thank you very much, John. Thanks, Deep, for running this morning, and welcome everybody on a Friday of a long weekend. Sultan, can you start the slides?
Yeah, sure. I'm starting them now.
All right, so our rounds today, it's going to be a slightly different format. We are going to have cases. So the title of the rounds is What Would You Do? We've got some thought-provoking clinical scenarios, and we hope to have an open, honest, safe, and interactive discussion. We have a panelist here today. Thank you very much. I will introduce you in a minute. And these issues involve medical professionalism in our everyday clinical practices. So I want to thank all of our panelists for coming, and we're going to have, I'm going to introduce them first. First, we have Dr. Hal Chu. He's a cornea specialist up at Sunnybrook Hospital. He had an engineering degree before going into medicine, and one of my co-residents when we were in residency at the University of Toronto. Thank you, Hal. We have Dr. Myrna Lichter. She's a comprehensive ophthalmologist in community practice and also at St. Michael's Hospital. She has a heavy interest in inner city health and Indigenous health. Thank you very much for coming this morning, Myrna. We have Dr. Natalie Pessin. She's a comprehensive ophthalmologist working in group practice in North York, as well as the Kensington Eye Institute. Thank you, Natalie. We have Dr. Sean Singer. Hi, Sean. He's the Director of Comprehensive Ophthalmology at the University Health Network, Toronto Western Hospital. We have Dr. Richard Weinstein. He is a comprehensive ophthalmologist. He's in comprehensive ophthalmology practice with a focus on cataract and medical retina in the Kitchener-Waterloo area for the last 20 years. He has an interest in telemedicine solutions and has recently started an incubator for early stage med tech companies, which is very interesting. I looked at it, iStart.com. Thank you very much for coming this morning, Rich. So we're going to have 3 cases this morning talking about medical professionalism. Our objectives this morning is what it means to be a professional, a review of medical professionalism, and then a discussion of medical professionalism in common clinical scenarios in ophthalmology. So we've got 3 cases. We're going to present the cases. We're going to present some polls associated with the cases, and then we're going to start our discussion around each case. Okay, so I'm going to hand it over to our residents, Erin Chan and Sultan Eldris, who've put a lot of work into this presentation.
Yeah, so before we dive into the cases, we thought it'd be important to do a quick recap on what medical professionalism is and why it's so important. So in fact, in 1999, about 20 years ago, the Accreditation Council for Graduate Medical Education in the United States, which is essentially the organization that accredits all medical and surgical residencies. I think you can kind of think of it as our equivalent to the Royal College. Outlined 6 core competencies that they wanted for all their trainees. I thought, so alongside medical knowledge and procedural skills and patient care, professionalism was outlined as and highlighted as a cornerstone competency. I thought this was interesting because for something that carries so much weight and importance, and indeed throughout my own medical school training, we got graded on our professionalism quite often. There is relatively little discussion and airtime for teaching and building professionalism within our curriculum. So when I think about professionalism, I think about behaviors that kind of go without saying. For example, being punctual, being presentable, being polite. But I think the more we are explicit about being professional, the more it allows us to reflect on what we do and why we do it. It makes me reflect on deeper questions as to why I became a physician in the first place and why physicians are held to a higher standard in society and afforded more privilege as a result of this. the ACGME spelled out principles that they wanted their resident physicians to abide by, namely to treat all patients with respect, compassion, dignity, for all residents and really physicians to have the patient's needs supersede their own self-interest, and for doctors to accept accountability to a patient's colleagues and society as a whole. Next slide, please. So about a few years later, in 2002, the American College of Physicians, in collaboration with the American and European Societies of Internal Medicine, published this charter on medical professionalism in the Annals of Internal Medicine. And next slide. And this charter essentially was a declaration for all physicians to commit to a number of things. And I've outlined them here, and I think it's good to go through them. So it was really a commitment to professional competency, a commitment to honesty with patients, a commitment to patient confidentiality, a commitment to maintaining appropriate relationships with patients and colleagues, a commitment to improving quality of care, access to care, and a just distribution of finite resources, a commitment to evidence-based medicine and scientific knowledge, and finally, a commitment to maintaining trust by managing your conflict of interest. And so with these things in mind, let's move into our cases.
Okay, thank you so much, Aaron and Dr. Sit. Okay, so we will be presenting 3 different clinical scenarios related to professionalism that are commonly encountered in clinical practice. And although they are inspired by common clinical events, they are fictionalized here. And I must say, these clinical scenarios, like my team and I, we thought of doing something different. And instead of presenting the cases as just a plain text, we thought of doing something different and videotape all the clinical scenarios. We hope you enjoy them. And I must say that they don't relate to any specific person or place in specific. Okay, so we will be moving to our first case, titled "Running Behind."
This is Dr. SLD. He is an ophthalmologist in his community that has been practicing for the past decade. He has treated many patients and is highly regarded by his colleagues. During COVID times, Dr. LD is mindful of not having people wait too long in his waiting room. However, today has been a particularly busy day and he's already running quite behind. The next patient he sees is Mr. Lee, who he knows is quite a chatty individual. He's quite nervous about being behind. Let's see how his interaction goes.
Good morning, Mr. Lee. How are you?
I've been better. I've been waiting a very long time, Dr. Aldi.
I'm sorry, Mr. Lee. You know, it's a very busy clinic, and it's during a very busy time, and I'm very sorry that you had to wait, Mr. Lee. So what's bringing you in today?
Well, I just want to say it's the morning, so I don't know why we're so far behind already. But anyways, I'm here because of that drop you gave me.
Do you mean the Zolatan that I gave you 2 months ago?
Yeah, that's the one. I think it's used to treat my glaucoma. But anyways, that drop you gave me really irritates my eyes. Every time I use a drop, my eye turns red, it starts itching and burning, it's super irritated. I used it like every night like you told me to for like a month, but I couldn't tolerate it anymore. I don't even understand why you gave me a drop like that. Like, didn't you know that this would be a problem for me?
That's very unusual, Mr. Lee. I give most of my patients Zolatan, and rarely someone complains of red eye.
Well, I don't know what went wrong. You know what? I even looked at the box. It says one of the side effects is redness and irritation. And so that's what I had. I don't know why you gave it to me. I don't even know why I have to take it. Do I actually have this glaucoma that you talked about?
Lee. It's okay, Mr. Lee. I'm gonna give you a different prescription for another drug, okay?
Okay, will this cause me to have a red eye?
No, hopefully not. Hopefully not.
Well, I definitely don't want it. That was like really the worst time of my life. I don't understand why you would prescribe something like that. Like, it doesn't make sense. Like, did you not read the box before you decided to prescribe that?
Okay, Mr. Lee, so you can actually get this drug from the pharmacy. That should not give you red eye. And if you have any concern, let me know.
So
I'll see you back in a month.
Should I stop the other drop then and
you
use
can
this
stop
one?
it. You can stop it. I'll see you back in a month, Mr. Lee.
Okay, but like, what is, like, is it every night?
That's,
like,
the pharmacist will explain to you everything, okay? I'll see you back in a month.
But
Okay, so this is our first poll over here. With professionalism commitment, resonates with you the most from this scenario? First, professional competence. Second, maintaining appropriate relationships with patients. Third, honesty with patients. Fourth, improving access to care. Just give it a few more seconds over there.
All right, so we'll end the poll here. I'll share the results.
Okay, so most of the people chose the second choice, maintaining appropriate relations with patients. Okay, so we will move now into our second poll. Which professional behavior or lapse-in resonates with you the most? Practices include practices in an ethical manner, shows respect for patients and family, listens carefully, answers questions from patients and family.
Well, this is a bit more of a split here, interestingly. Well, not interestingly, because there's many lapses in that video, but here are the results for you.
Okay, yeah, as you said, almost like a third and a third and a third. Okay, that's nice. We will move now into our third poll. Is it okay for physicians to run behind schedule? First choice is no, it's unethical to run behind schedule, especially during a pandemic. Second, yes, clinics can be unpredictable. The physician should not be blamed. Or third, no, the physician should plan. His or her day accordingly by scheduling appropriately.
All right, we'll give it a couple more seconds here. In an audience of mostly physicians, no surprise here.
Okay, yes, so most of the people chose number 2, which is yes, clinics can be unpredictable and the physician should not be blamed. Interesting, it's gonna open a good discussion. So we're gonna have some 5-minute discussion over here led by Dr. Sit.
All right, so we've got our panelists on. So, the point of this discussion is to hear multiple opinions. So let's start. I'm going to call, so I hope you don't mind, I'm going to call on one of our panelists one at a time. So let's start at the bottom of the alphabetical order, Rich. So Rich, what did you think about the issue of what is the professional lapse or the behavior that resonates with you the most?
It's interesting. Certainly, if you went through all the topics you had on the poll, you could argue that all of them were not met. At the same time, I feel like I live this every day. So I don't think it's a pandemic issue. I think this is something we all face. And there's certainly different ways of approaching this. You gave a great example of someone who rushed through, who didn't communicate, who didn't answer questions. But to the residents, I'll say this, that as you go out and you have a busy practice and you're seeing 50, 60, 70 people a day, this will happen to you all the time. And I'm not sure how easy it is to avoid. I think obviously it could have been handled a little bit differently. You could have answered the questions a little bit better. You could have said, I'm happy to have you come back again in a week or two. We can discuss this in greater detail when I have more time. But this is ultimately going to be a problem that we're all going to face continually going forward. I think as long as you're honest with the patient, as long as you could have spent a few more minutes talking about this in a little bit greater detail, even if you're behind, I don't think a minute or two extra would have been that much of an issue.
Great.
Well, could I just ask Rich, do you think the problem is that we're seeing 70 patients a day? And we see more than that sometimes. Should we be seeing less as ophthalmologists? In
a perfect world, Sharif, you're 100% right. The argument that 65% of us said, yes, clinics can be busy and therefore this is understandable. If you flip this around and ask the patients what they felt, I guarantee you wouldn't have gotten 65% who said, yes, this is acceptable.
So maybe we need more ophthalmologists per unit number of patients. Maybe we need more than 400 ophthalmologists in Ontario, especially given, we have the same number of ophthalmologists in Ontario as we did 30 years ago. We have, the demographic has changed completely. We have many, many more patients, many sicker patients. Do we need to start creating more ophthalmologists in this province?
Those are good questions. I mean, we have a finite amount of resources in Ontario, and we have to, and a lot of professions would say the same thing, where they also have finite resources. And even within ophthalmology, we feel we have finite resources within the different areas, where different areas are competing for our resources. So,
But you know, right now, Marissa, the resources aren't clinics. The resources are surgery. And it's really the surgery. And for a comprehensive ophthalmologist, it's the cataract surgery. And so it's something that I think it's a discussion we need to have again about, do we need to look at the number of surgeries each ophthalmologist does in this province? You know, we talked about capitation of surgeries. And of course, you know, the academic centers have a cap of about 600 surgeries per ophthalmologist. So maybe that's stiff. Maybe we need to look at the 90th percentile, which might be 1,000 cases per ophthalmologist. We're going to see an expansion in the number of cataract surgeries in this province over the next few years. And if we manage these resources right, we can start increasing the number of ophthalmologists. And more importantly, we can start giving some of the ophthalmologists who don't have resources some resources. Maybe those directions can help us a lot with our professionalism.
yeah, those are good ideas. Let's move up to Sean. Morning, Sean. So what would you do exactly when how could this have been handled differently or better? We need some.
You can hear me. I was having a little tech problem. Am I good?
Yeah, I think you fixed it.
Good. So I think there's, I find that when we do fall behind, which is inevitable, that in fact, giving that patient a little bit more time tends to be quicker, because ultimately, you're not going to be able to get them happy unless you give them the time, and they're going to keep going on and on and on. And so my approach varies really, if it's the first time versus, I've had patients say, I've never had to wait before. And I go, well, then, cut me some slack here. And I'll often say to patients, it's very unpredictable. We see a lot of emergencies. We try and book appropriately, but inevitably days like this happen because people come in with problems and I have to give them time. And rest assured, if you come in down the road, you call with an emergency, you know that we will squeeze you in and I will give you the time necessary to manage your acute problem. And that takes all of 15 seconds to explain and usually ends the discussion right there. As far as just wanted to go back to address some of Sharif's comments, I think the demand is unlimited. And, I've had patients complain to me in the same breath about waiting months to get an appointment and hours sitting in the waiting room. And my answer is, well, you're allowed to complain about one of those, because you can't complain about both, because then that's beyond my control. And the only way to see you quicker is to squeeze you in, which inevitably leads to longer delays in the office. So we're in a predicament. And there's no easy answer, but just to address the particular clinical scenario that in the video, I find just giving that 15-second explanation of, we see emergencies, you get an emergency, we will squeeze you in, let's move on, usually is the quickest response.
Great, thanks, Sean. Natalie, what do you think about the trust between the patient and the doctor in this scenario?
So it's definitely been broken here. If the patient is not, if the physician is not giving them the time to answer their questions, then they're not going to trust you. And they already didn't trust the doctor who prescribed the Xalatan. They weren't sure why it was prescribed. And so how are they supposed to build that relationship if you're not giving them that time as well? And so definitely, just like Sean said, if you give them that extra little bit of time to help them have the autonomy to really understand the situation, I think that that relationship will definitely be stronger and they'll have more trust in their physician.
Great. Thank you. Myrna, I want to ask you, what do you think about informed consent in the patient's treatment in this scenario?
Well, that's an interesting problem. As I'm listening to this, I realized, one of the things I said is you have to manage patient expectations, and certainly I certainly feel that the patient should be. You can't avail a patient of every single side effect of every medication. I mean, how many of you tell them that Xalatan may give them asthma? I mean, it's so rare. I think I've had one in 30 years of experience. But what you do say, but I think that consent implies that if they're having any problems with any medication, that they should know that they should be stopping the medication and calling the office. And that's always the last thing I ever say to a patient when they leave with medication. It's hard to give total informed consent because there are so many side effects to everything that what you do, but having the conversation that if they experience any problem, that you're available to them is I think the best technique. That's my opinion.
Great, thank you.
So you've got a comment here from the audience.
Yes,
Trevor. Yeah.
Yes, it assumes that Trevor says, one assumes incorrectly that all patients are prompt for their appointments. On the matter of Mr. Lee and the red eye, he should have been told before treatment about the diagnosis and the potential side effects.
Absolutely.
Yeah, I mean, Hal, why don't you speak to what do you do, Hal, when patients are not prompt? We have a lot of patients, and the 9 o'clock comes at 8, and the 10 o'clock comes at 8, and the 11 o'clock might come at 8. So what do you think is the best way to handle something like that?
Yeah, it's tricky because that's kind of everything translates to that, and you can just explain. I think exactly what Sean said. First of all, and I just echo what everybody else has said. You have to for that extra 10 or 15 seconds or even 30 seconds to a minute to explain to them what's happened. And sometimes it's just a matter of saying, unfortunately, we were quite quiet from 8 to 9 o'clock, and then the bus came in at 9 o'clock and everybody showed up all at once. So we're a little bit behind, and I apologize for that. I think once you start with apology first, it kind of, tampons down the heat. The patient then will kind of settle down a little bit. If you go back at them right away with, well, something, you're supposed to be here at 8 o'clock and it's 9:30 right now, it's not, you're just amping up the pain and the anxiety. So I think you have to kind of settle things down a bit, just a quick apology, very sincere apology, and just say, let's, how do we start with this? And then, at the end of it all, you can summarize it by saying, and just finish by saying, I really apologize for waiting. This is a tertiary care center. We do take care of a lot of patients. We do have a lot of emergencies here, and it is unpredictable. In the future, if you would like to come when it's a better time, usually I book an hour and a half off for lunch, which I never get. I usually get minus 15 minutes for lunch because we run overtime with emergencies, etc. But usually the person that comes at 1:30 is usually seen pretty efficiently, much as the person who comes at 8 in the morning or 7:45 in the morning, they're in and out usually pretty quick. So I give them options. One last thing, you're right. If unfortunately, the patients, when you give them the 15, 30-second explanation, and most times that works. But as we all know, there's some patients who require another 45 minutes, even despite what you say. In those cases, I'll tell them, I'll say, I apologize, but there's a lot of other patients waiting. And I want to make sure that I give you your due time. So how about you sit outside for a little bit? Let me take care of a few other patients first, and then I can get back to you. Or I can say, something, this may take a long time and I don't want other people to wait. There's a lot of people waiting even longer than you. Would you mind if I called you at 6 o'clock tonight and I can talk to you? Unfortunately, it means a lot of late nights, but for those patients, sometimes it's better to diffuse things right then and there. And I find most people are amenable to that.
Great. Those are great suggestions, Hal. Thank you. Alan, you've got your hand up. Alan? Does Alan Slomovic have his hand up?
Alan, you're muted.
So I just wanted to say, first of all, I think congratulations, because this is a great problem that each one of us faces. And I think some of the solutions are very creative. What I'm going to mention is almost a variation of what Hal said. I think there's two kinds of patients, one that just wants to talk to you, and the other one that wants to ask you questions. And what I've done sometimes, fortunately, we have more than one examining lane, and I validate the patient's comments, saying, look, you've got a lot of interesting questions, but there are a lot of them. I'm going to ask you to try to think about it a little bit, formulate 3 of the top questions that you've got for me today. I'm going to be back in about 10 minutes or 15 minutes, and I see another patient. And when you come back, I mean, you've got a little bit of a more coherent questions that are being asked. Also, they've been waiting a little bit longer and they want to get going too. So they will condense their questions a little bit as well. And I found that to be helpful.
Great. So that was a great discussion. Thank you, everybody. I mean, it touched on so many issues. We'll summarize them all at the end. We're going to move on to the second case.
Okay, so thank you, everyone. So this is our second case. My doctor says you're the best.
Hi, good morning, Mr. Chang. How are you? I'm Dr. Aldi. Dr. Su has referred you to me.
I'm so excited to finally have met you. Dr. Su and I go way back. She's been my optometrist for the last 15 years, and she sent me specifically to you because she says you're the best. And she says, anyone has to touch me or shoot a laser into my eye, you're the guy to do it. So I'm really honored to meet you. She says you're the best guy and you're the nicest guy.
She's lovely.
So
She's lovely. She's a good friend of mine. Thank you. Thank you for coming and thank you for your trust.
Okay, you know, I really appreciate it. Yeah, she said that I needed to do a special laser in my eye to clear up something about my drainage being tight. And if I don't do this laser, then I might lose my vision. And so that sounds pretty scary. She said, I only trust one guy to shoot this laser, and it's you. So like, once again, I'm really glad that we're gonna get this done. I'm glad it's in your hand, and I have my utmost faith and trust in you. So yeah, let's get this done.
Perfect, Mr. Chang. Okay, let's take a look.
Okay, so these are the examination results. As you can see, the vision is 20/20, pupil equireactive, pressures are normal, slit lamp and frontal examination within normal limit. The angle was wide open. So this is our fourth pull over here. How will you proceed? You will, first choice, you will proceed with the PI because this optometrist is your friend and sends you lots of referrals and you don't want to offend them. Second choice is you proceed with the PI because this patient has a trusted relationship with optometrist and you wish to maintain patient-centered expectations. Third choice, you will not proceed with the PI as the patient does not need it.
All right, so we've got a pretty overwhelming response in one direction. So I'm going to end the poll here, Sultan.
Okay. Okay, as expected, yeah, 100% for the third choice. Okay. So this is what happened. This is a discussion that happened after the examination.
Okay, Mr. Chang, I know that Dr. Su referred you for a specific laser procedure in the eye. I know you came here today expecting to have this procedure. But as you can see, we did multiple testings, we did extensive examination, and based on my professional opinion, you do not need this procedure.
Wait a second. So you're telling me I don't need to have this laser?
Yes, based on my professional opinion, based on the testing we have done, you do not need this procedure.
But Dr. Su spent like an hour with me and I trust her with my life. And she said that if I don't get this laser done, I may lose my vision. And that doesn't sound like a good thing to me. Now, I have a family history of people who've lost their vision. I really don't want to fall into that category. So I came here today all this way. She really talked you up and she said, you're the guy that's going to do this laser for me. And now you're telling me that I don't need to do this laser?
I understand this, Mr. Chang, but based on all the testing we've done, you do not need this laser, and all lasers have their own side effects. So I don't want you
Well, she explained the risks and the benefits, and I'm very motivated to do this. She's told me like there are minimum risks, and what the benefits are, it confers a lot of protection. And I understand, yeah, there's going to be some drops afterwards. There may be a little bit of irritation, but like, yeah, I think we should probably still go ahead with this laser.
You know, Mr. Chang, like, again, like, you do not need this laser, and the laser also has side effects. I don't want to subject you to these side effects, and you actually don't need it.
So what are you saying? Dr. Su doesn't know what she's talking about?
Okay. So we're going to our discussion over here. So I'll hand it over to Dr. Sit.
Yeah. All right. So a bit of a different case. I mean, we often have these situations where we have a relationship with an optometrist that refers to us. Let's start at the top of the alphabetical order. Hal. What do you think about the relationship between the optometrist and the patient here versus your relationship with the patient?
I think it's nice to get all that information, but I think it's really superfluous. I don't think it really adds. I mean, in terms of what your medical decision is, you have to do what's right for the patient. Yes, it is nice that they have a relationship. Again, some patients claim they're best buddies with whoever or not. Maybe they're not, maybe they are. I have so many patients who say that they're best friends with Ike Ahmed's mom, so it's just, it's very, you don't know what to make of that. So, but you treat the patient professionally with the best medical evidence and what you think is right, and you go forward with that, and you say, I'm really sorry, but I think this is what I think. I think Dr. Zhu sent you here for an opinion, and Dr. Zhu was thinking one way or the other, and if you really want a second opinion, just to confirm, that may be a good option for the patient.
Great, thanks. Myrna, what do you think about conflict of interest here, the issue of conflict of interest, where you get a lot of referrals from the optometrist? Can you comment on that, Myrna?
You're on.
I honestly believe you always will act in the best interest of your patient. Now, you don't want to undermine an optometrist colleague who's very conscientious. And I certainly would say, in my opinion, I don't agree with Dr. Chu. And with your permission, let me talk to Dr. Zhu and let me see, maybe we could get someone to break the tie. And I agree with Hal. I mean, I would say, I'm going to send you to someone who specializes in glaucoma. I think one thing, Dr. Chu thinks another. That doesn't mean that, let's find someone who will break the tie, who's a glaucoma specialist. And I think, and I would certainly play up Dr. Zhu, because I need her, not to refer to me. I need her because she's servicing the community, and she's obviously serviced this patient very well, and he trusts her. So I think that's important. Sorry.
Natalie, so the sticky issue here is that, often we see patients who've had a long-standing relationship with their optometrist, but, we're consulted on the one opportunity, one chance here where we have a completely new relationship with the patient, whereas they've known their optometrist for like 10, 15, 20 years, right? How do you handle that? And this could be, it's not even just the PI issue. Like sometimes we see uveitis patients, for example, that have been handled maybe by their optometrist. So similar issues.
Yeah, so I think I agree with what Hal and Myrna have said. You obviously have to be ethical, you have to be honest. If your opinion is different than the optometrist, you have to tell the patient that. We can't be judgmental. You're not going to bash the optometrist. You're not going to say, you're not going to say bad things, but you're going to give your personal opinion, your professional opinion, and hopefully that if you can explain it thoroughly, the patient will understand. And if not, sometimes a second opinion is helpful, just like the others have suggested. I often do offer that to my patients if there's some sort of disagreement or I'm seeing that they need just another opinion.
Okay. Sean, so let's just flip it a little bit. Say you had say that you saw the patient and you said you don't need a PI, and they went to see somebody else who said they did need like another colleague of yours, and then they come back to you and say, Dr. Singer, you said I didn't need this.
Well, I think, in some cases you can explain that there are borderline cases and that some people will interpret the results differently. Some people are more aggressive than other in terms of their management. And you want to talk about that the treatment has to be tailored to the specific patient, specific scenario, et cetera. So again, I think the second opinion or third opinion in this scenario is always a safe bet. Certainly you don't want to get bullied into anything, doing anything that you think is clinically inappropriate. The other thing that I'll often do, just going back to the original situation, is I'll emphasize, particularly if it's an optometrist or another ophthalmologist, eye care provider that you've had a relationship with, is to say, caution is better in this case. And so I'm glad the Dr. So-and-so sent you to me because they were concerned, and that's certainly the right thing to do. And I know that they'll be happy to hear that we decided that you're fine. And so emphasize that relationship is good, because in most cases, the patient has been receiving good care. It gets a little trickier when it's somebody who you don't know at all. And the patient requested that they be sent to you for a second opinion or a third opinion. But again, it's easy to explain, if in doubt, we want these patients, I want to see people like you to make sure that you do or don't need it. So emphasize that referral is easy and you want to be overly cautious.
Okay, we have a couple questions from our panel. I think one was, so I'm going to call upon Rich here. So the question is, it's easy to get a second or third opinion in the GTA, not so easy in other parts of Ontario. So Rich, you work out of like Kitchener area. How would you handle like that scenario?
Well, fortunately, I have 3 glaucoma specialists in my practice, so it wouldn't be hard to send them across the hall. But even in a case like this, where this, you've already determined this truly isn't an urgent issue, I don't think it would be a problem to get a second or a third opinion anywhere in the province. Even if it took 3, 4, 5 months, I don't think that would be an issue. And I would echo what everyone else has said, that you obviously have to try and maintain the relationship between yourself and the patient, yourself and the optometrist. There are lots of ways to explain this to the patient. You're being referred to me for a reason. You're being referred to me because I'm supposed to have the expert or the expertise to explain to you what we should or shouldn't do. I think, you don't want to be knocking your colleagues, but I often tell the patients that, because this happens to me all the time, whether it's for a PI or for a cataract or for a peripheral retinal lesion, I usually say that I do these procedures, the optometrist doesn't. I have greater expertise in this. This is my opinion. And again, when I look for a second or a third opinion for a case like this, it's usually not an issue.
Great, thank you. And Trevor had a comment.
I think John might have a comment. He's got his hand up.
Sorry, I didn't see that. John.
I wanted to mention that I often find myself in this scenario, and I like to say that, using the slit lamp, the angle maybe looks narrow, but when I put the special lens on your eye, I can see a little more detail and see that it's not the case. And this way I sort of validate the optometrist's opinion that it does look narrow, but this additional testing allowed me to see that it wasn't actually necessary. And this way the optometrist is still correct, and we can still, reassure the patient that the procedure is not needed. And almost invariably they're relieved not to need the procedure, but that's all.
Great, thank you, John. Yeah, definitely this is a scenario that so many of us see every day in our clinical practices. So it's great to hear all the opinions and all the actual real life, how we each deal with this scenario. There's a couple comments. One other is also how Trevor says these relationships with optometrists are essentially suspect. One can tell the patient that an objective test such as a UBM or an anterior segment OCT can clarify the issue. The other comment is, how about our social responsibility to limit costs to the system? I tend to save my referrals for second opinions for more questionable cases. I agree, like it's difficult. We cannot send every patient for a second opinion, and that's why we, proceed with a conversation with the patient first, I think, as we all had said, to try to meet the patient's expectations with what we think is medically necessary and the responsible and conscientious thing to do. But I think in some situations where the patient is certainly pressing, or you feel that the patient will not be satisfied upon leaving, then a second opinion might be helpful in that situation. But yes, we can't send all of our patients for second opinions. I think we're going to move on again, just to make sure we get to our last case and save a little bit of room at the end, just for common themes that have come up. I know, Sharif has also mentioned in a comment that we haven't fully addressed the issue of resources. So if we have time, we'll definitely come back to that, Sharif. Sultan.
Sorry, I was muted. Okay, so this is our third case, titled The Second Opinion.
Hi, good morning, Mr. Wong. How are you?
Hi, nice to meet you.
Hi, I'm Dr. Aldris. Nice to meet you. I can see that you have been referred by your family doctor for a second opinion regarding cataract surgery.
Yeah, that's correct.
How can I help you?
Yeah, so actually I saw an ophthalmologist a few weeks back, and he told me that I needed to have urgent cataract surgery. I had just gone in to get a glasses prescription changed, and he told me that I was developing these cataracts and that he could get them done for me very quickly. And there was actually quite an exorbitant fee associated with it as well. But anyways, I didn't feel too comfortable, so I thought the prudent thing to do was to maybe get another opinion, so that's why I'm here.
Nice, nice. So I'll just ask you a few questions. Have you been noticing any vision changes recently?
Well, yeah, maybe mild changes, but not so much. I haven't really noticed much.
Any
changes.
problem driving at night?
Oh, no, certainly not.
And do you notice any like glare or halos around light sources?
Nope. I don't notice any glare.
Have your prescription changed recently?
My glasses prescription?
Yeah.
No, I haven't had any changes to my glasses prescription.
I see. And any problem reading?
I mean, I have my reading glasses, as I normally do, but it seems that I know every few years the reading power jumps up a little bit.
I see.
But with the glasses on, I have no troubles reading.
I see.
Yeah.
Okay. So let's take a look, okay?
Okay.
Okay, so these are the examination results, as you can see. Vision 20/20, people equally active, normal pressures. Straight line examination showed trace microsclerosis with mild anterior cortical spokes in both eyes. The red fundus examination was normal. So we'll go on into our fifth poll over here. Given the examination in the previous slide, how would you proceed? First choice, you will offer Mr. Wong cataract surgery since he will eventually need one. Second, you advise Mr. Wong that he could have cataract surgery and that he should go back to his original surgeon for it. Third choice, you will tell Mr. Wong that he does not need cataract surgery with your reasoning and offer him to follow up. The fourth choice, you will tell Mr. Wong that he does not need cataract surgery and that his surgeon may not have made the right decision. A few more seconds. Okay, so almost 93% with the third choice. You will tell Mr. Wong that he does not need cataract surgery with your reasoning and you offer him a follow-up. Okay, so this is the interaction that happened after the examination.
Okay, Mr. Wong, you came here today for a second opinion regarding your cataract. And based on the extensive examination that we have done, you have very small cataract that you don't seem to be bothered by it. Based on my professional opinion, I think we can just observe this on an annual basis and we can see you back in a year.
Wow, that is very shocking to me because just a few weeks ago I was told that I needed urgent cataract surgery. So why did he tell me I needed urgent cataract surgery and you're telling me that we can just monitor on a yearly basis? I guess the other question that I have for you is that he had quite an exorbitant fee associated with his surgery. How much would it cost to have surgery with you?
Yeah, if you choose to have your cataract surgery with us, we would put you in the waiting list, and you have the option of going through all-head coverage, and in this case, all-head will cover the cost of the surgery and you don't have to pay. But if you're willing to have some upgraded options, there is associated fee with it.
Okay, so just to recap, the recommendation for you is that I have small cataracts that are not really affecting my day-to-day living, and in your recommendation is that we don't need to do surgery and that I could just watch it for now.
Yes, you can be monitored on a yearly basis.
Okay, so should I monitor back with you, or should I go back and see the surgeon that I originally saw?
Okay, so after this interaction, this is our 6th poll. You decide not to offer cataract surgery. From Mr. Wong. And Mr. Wong asks, so my original surgeon does not know what he's doing? How would you respond? First, I'm sorry that I can't comment. Second, yes, he does not know what he's doing. Third, I think he made a wrong judgment. Fourth, no, I think your surgeon is a good doctor. I'll give it a few more seconds.
This is not an uncommon scenario, Sultan. So thanks for sharing
Yeah,
that.
yeah, we actually face this a lot in clinical practice. Okay, so almost half the people chose the 4th option. No, I think your surgeon is a good doctor, and I think it's the right answer to say in these cases. Okay, so we'll just hand it over to Dr. Sid for discussion.
All right. Yes, I mean, that is a very common scenario. And I find some that, so we're going to start with Rich. We're going to start at the bottom of the alphabetical order this time. So Rich, what do you think about when, the question about, well, what do you think about the doctor who told me this? That very common question we're asked all the time. And a very difficult question that makes it a little bit uncomfortable sometimes.
It's interesting, and we could talk about self-policing within our profession for the next 3 hours and still not come up with a solution. I usually don't try to get into a conversation where I make comments about the person who referred. I usually like to leave it to, what is my medical opinion? What is my exam? What have I discovered? I often ask them leading questions so they can come to the solution on their own. So if you say to them, do you have any visual symptoms? They say, no, not really. Does this bother you? No, not really. Then why do you think you need surgery? And I find most of the time the patients, after a really short conversation, can come to the understanding that this isn't necessary. But I don't go out of my way to try and make a comment about someone. I think it's never helpful. The patients are educated enough, for the most part, to understand what they have and what you can do for them going forward. But I see this every day.
Yes, I agree. I mean, Sean, what do you think if the patient was pressing you on the issue, Sean? Like he's pressing you in the office. He's not going to let you go till you say something.
So again, I'll talk about, just like patients, surgeons have different personalities. Some are more aggressive, some are less aggressive. And often in this case, a comment that often dampens down the tension is to say, look, there's no doubt you will need cataract surgery at some point in your life. So we're not talking a yes or no, we're talking a now or later scenario. And that usually is enough to calm things down.
Great.
Just in terms of another comment about second opinions, often I'll see second opinions after the surgery where people have a problem. And when I recognize that that's the issue, one of my leading comments is, I'd prefer if you don't tell me who your surgeon was, because if it's, a good friend, et cetera, I want you to know that I'm going to be giving you a very honest opinion. So I'd rather not know who gave you either the surgery or the opinion that you need surgery. And I think patients often appreciate that offer.
Yeah, I like that comment about not knowing who the other surgeon is, because it removes a little bit of conflict of interest if there was one that existed. So I think that's a great suggestion too. Natalie, what do you think about the anterior cortical cataract in this? Cataract, it is very subjective in some ways. And how do you deal with that scenario where patients might have a little bit of an anterior cortical cataract and they're there to see you for a second opinion?
Natalie, you're muted.
Thank you. Sorry about that. I was just saying it's definitely something we see on a daily basis. Just because there is a little bit of a cataract there doesn't mean it needs to be operated on. And like Sean said, you often, or Rich said, you just ask the patient about their symptoms, how they're feeling. And that often does dictate what they choose to do, if they think they need surgery. And if they're not bothered, they're not going to want to have surgery. So just because there's a cataract there, doesn't mean you have to touch it.
Great, thank you. And we have a comment from the chat here. It says, if it ain't broke, don't fix it. So I think that's very apropos there. Myrna, what do you think about the follow-up of this patient then? So we're sent for second opinions, but where does this patient go afterwards? So if you disagree with the other physician, Myrna, where will this patient follow up?
Actually, I've often been on the other side where I've sent a patient for cataract surgery and the surgeon comes back and says, I don't think they need it. And I have to deal with the patient who comes back to me and says, well, what do I do now? I usually explain to them that it's risk and benefit, and that nothing is without risk. I think they should be sent back to the referring optometrist or ophthalmologist if that person is reasonable, or you can offer to follow them yourself. But I think what you should say is, in a risk-benefit situation, I sent you to a good surgeon, and if the surgeon has decided that the risk outweighs the benefit at this stage, like, I'll go along with that. I said, you always risk getting thrown back, when you catch a fish, and there's no harm in waiting. They'll often come to me and say, well, what's going to go wrong if I wait? I said, nothing. You're just going to progress, and as soon as you're more symptomatic, I'll send you back. Now, for a surgeon, the real issue is the surgeon that wants to operate. The issue of charging always makes me very uncomfortable. And I think if the surgeon has not had the conversation that there is refractive cataract surgery versus medically necessary cataract surgery, I'm uncomfortable with that, I have to be honest. If they have not had that honest conversation with the patient.
Yes. We have a couple of comments here. One is, it's helpful to acknowledge to the patient that not all medical decisions are black and white, and that different providers will have different experiences and opinions. Or can this have a negative effect on the patient view of the system? So that's a great question right there. We're going to come back to it. There's another comment. The patient may be looking for a refractive lifestyle benefit. All right, so Hal, what do you think about the negative effect of the patient's view on the system? I mean, from our lens looking, we see it a certain way, but from the patient's view looking, they think, I'm being put here and there, and I've got different opinions. It doesn't make a sense to a lot of people.
Yeah, it's challenging because some people do have, there are some patients who actually do have some visual issues, and maybe they thought is all due to their cataract, and they heard from their friend that they had a cataract and surgery and they did great afterwards, and this will cure them of their dry eyes or other things, which is a common, misconception that we see. It's difficult. I think you just have to listen to the patient and see. I think exactly what Rich and Steve Kosar said. You get what the visual issues are. Then you relate it to what your medical findings are, and you can explain to them what it is to try to, get them to make the right decision. Now, the problem is, a lot of it comes into play where, unfortunately, rightfully or wrongfully, there are some places where, a patient can go there, they can get their refractive lens exchange done. Sometimes the patient doesn't want to pay that money, so they end up on someone else's doorstep. And it's hard to talk about that. I basically, I don't throw the referring doctors or optometrists under the bus for anything, because you don't know what the discussion was with the patient. You don't know if there's anything else going on, and you don't know what the exam was either. So it's hard. I think you just have to go on your own principles and say, this is what's happening. I think you're okay. I don't think cataract surgery is going to help you. And I commonly say the risks outweigh the benefits at this time. Eventually, you will need cataract surgery at some point, but like Sean said, I don't know if that answers the question. But.
I think it does. Thank you very much. it's great to hear all the opinions and how you would actually respond to the patient, because I think it's useful for, you know, our colleagues and also our residents to know, you know, some of the phrases that we use, and some of them might resonate with patients better. So it's interesting to hear how everybody handles it. Alan, you've got your hand up.
Just a quick comment and a follow-up to what Myrna said is that, you know, usually the patients who come in referred for cataracts do have a cataract. And, you know, in my letter that I dictate back to the referring doctor, I say that I certainly agree with you, and I do that in front of the patient, that there is a cataract there, and undoubtedly it will progress. And I'd be pleased to see the patient again when you feel that they're ready for cataract surgery. And that sort of just shows the patient that you and the referring doctor are online. You're seeing the same thing. Now it's just a matter of when.
I agree. I agree, Alan. It's sometimes and as Sean had said too, it's a matter of when we'll actually do it and when is an appropriate time that's comfortable for the patient and also for the operating surgeon. Sharif, you have a comment.
Yeah, Marissa, these are great cases, and it's wonderful that we can discuss these type of cases. You know, we did a multi-center study looking at cataract surgery and the pre-op CAT-QUEST and Snellen acuity, and we found about maybe 2% of patients who really didn't have significant cataracts that were being referred to for cataract surgery. And it was interesting talking to those optometrists we could reach out to. They were saying that they really don't know if we have a 2-year waiting list. And so they just wanted to plug the patient into the system. So it really comes out of a little bit of a misunderstanding. The patient is told they have a cataract. They don't realize that the optometrist thinks it's not that visually significant, but they want to get them plugged into a wait list. And that often is the reasoning. And so they're open to hearing that they might not be ready for surgery. I just wanted to comment also, you know, one of the concerns in the system, and Rich kind of talked about, he doesn't want to touch the whole policing thing, because he's absolutely right. We can talk for hours about how we self-police, but the idea of now we have very long wait lists, especially with COVID, and we have private centers, and private centers can get patients in very quickly. And we always run the issue of queue jumping, and that concerns a lot of people. Certainly concerns me, the idea that a patient is seen and is told, well, and in this case there is a visually significant cataract, and is told, well, you know, you can have this option where you pay nothing, but it'll probably take 1.5 years for you to have surgery. Or if you choose to have a multifocal lens and all the tests that go with it, I can do your surgery next week in a private center. And that effectively is paying to jump the queue. And that's professional misconduct, according to the CPSO. Unfortunately, CPSO just doesn't have the teeth to do anything. And so we see this kind of queue jumping happening all the time. I really think we need to look at our how we self-police and how we self-regulate, and how can we control these issues given our long wait lists and other things that exist in our profession.
I agree, Sharif. It's like there's a lot of issues that come up with these cases. It's interesting that, you know, these cases come up every day in our clinical practices, but there's so many small issues that come up from them, and you know, all these issues constantly come up, and we become almost a little bit immune to it because we see it so often. But it's good to talk about it, and I'm glad that we've been able to have like an open, honest discussion here this morning about it. I'm sure we could continue talking for hours on end about everything that we've discussed today. There's lots of conversation that can happen from this. And hopefully we'll have a chance again, hopefully in person, to talk about these issues again. John, you made a comment. Patients sometimes misinterpret what the original surgeon told them. Cataract surgery may have been offered, but nothing actually said about it being actually urgent. And I actually agree, yes. So, you know, often we tell patients things, or we tell patients things and they don't hear. Maybe we did say it was urgent and they didn't hear the urgent part, or we didn't say it was urgent and they somehow interpret it as an urgent part. So absolutely, what the patient hears And what
sometimes surprised what patients will tell me. I still vividly recall a patient telling me one time, he said, last time I was here, doctor, you told me the reason I had glaucoma is I drink too much Coke. and I thought, there's no way I would have said something like that. But the patient might have left the room and said, do you think I drink too much Coke? And I'm like, yeah, Coke's not good for you. And, and then it gets spun around. So we always have to remember before we think too poorly of our colleagues, remember that there's often communication misinterpretation. And I think a lot of these scenarios that come up, when they're filtered by the patient, they are spun in a slightly different manner than the conversation actually went.
I agree. I mean, just as patients show up at our doorstep and say so-and-so said this, it could definitely happen the other way around, where, John, you may have seen a patient of mine that told you that I told them they drink too much Coke. So absolutely, it happens both ways. And I think we have to keep that in mind when we're dealing with patients and the conversations we have with them. I think our time is up. It's been a very interesting discussion. Thank you very much to all our panelists, Rich, Sean, Natalie, Myrna, and Hal. Also, thanks Alan, John, and Sri for your comments too. I hope we can continue this conversation on another time. But it's great food for thought and to think about these things in our daily practice. Thank you, Aaron and Sultan, for being Grammy-winning actors this morning. It was
we just received an offer from Hollywood.
Yes. Please stay and finish your residency.
All right, thank you everyone for a great discussion this morning. You asked the tough questions.
Thanks, Marissa. Great job, everyone. Thank you.
Thank you very much. So we have final rounds next week. It is an EDI rounds, equity, diversity, inclusion rounds. And I apologize, we have a guest speaker, but I'm not sure it is. But yeah, I'm sure it's going to be a fantastic rounds. Dr. Bakshi has arranged it. So thank you all, and we'll have a great long weekend, and we'll see you next week.
Have a great long weekend, everyone.